Hello everyone, welcome to KHA Homeopathy Study Group Pro Bono webinar. Good morning, good afternoon and good evening. So nice to see many of you from different countries and different time zones. Before we start, we would thank Universe for giving us this great opportunity. And this session, we will, Dr. Sweta Singh, our KHA Chief Administrator, she will start, followed by Dr. Nupur Shah.
Thank you, Dr. Kavita, and it is my privilege to introduce with all our KHA Homeopathy Study Group. KHA Homeopathy Study Group Pro Bono was organized and founded by homeopath and humanitarian Kavita Kukunur, President and CEO of Kavita Holistic Approach, KHA. This study group is intended to be an offering from Kavita to the homeopaths around the globe, sharing goodwill and solid clinical work within the classical model. Our foundational principles for the KHA mission and vision are very unique: to inspire young homeopaths, mentor, provide excellency for educational purposes using holistic approaches via webinars, which are based on principles of classical homeopathy, and provide professional continuing educational homeopathic credits for practitioners. We provide merit certificates for spreading the light of homeopathy around the globe. Dr. Kavita is a member of Kavin Friendly Foundation, a non-profit organization that helps to serve poor people in greater needs in India. She is the recipient of Martha Allman Community Service Award by National Center for Homeopathy and Best Entrepreneur Award from Dr. N. Linga Raju, Principal of JSPS Homeopathic Medical College, Hyderabad, India. We are extremely happy and proud that we celebrated 10 years of her book, Beyond the Limits, a challenge to prove oneself. This precious writing contains her true life experiences where she connected to homeopathic principle, with inspirational stories where she converted her obstacles and struggles as stepping stones for her success in America, and her passion and devotion towards life and homeopathic profession, dedicated to all proud women. As of now, we have over 250 plus recordings on professional webinars related to homeopathy, health related topics, and inspirational talks available on our channel, Kavita Kukunur. Dr. Kavita is also a part of Mission 5000 series of webinar. Experience her masterclass on achieving thriving practice in homeopathy, approved by RO, Australia, and ECHINA, USA. This webinar is moderated by KHA family, myself, Dr. Sweta Singh, Chief Administrator. It is being recorded as we speak and we are live on Facebook. We will take questions at the end of the webinar. We will post a jot form in Zoom webinar chat at the end of the webinar. Please fill that form to receive your certificate. And if you are watching live webinar, email us at khastudygroup@gmail.com. Now over to Dr. Nupur. Thank you.
Thank you, ma'am. I am Dr. Nupur from India, KHA volunteer. I welcome you all. I am very glad to be a part of KHA Study Group and would like to take privilege to read our code of ethics. To be a KHA speaker, need at least 1 to 2 months active volunteering. Only KHA speakers team are promoted in newsletter and webinars. KHA provide volunteering for 2 to 12 months. Respect and inspire volunteers to grow. Active volunteers will be promoted through our website, social media, and added to the WhatsApp group. Articles of the volunteer will be posted on KHA website and newsletter, and will be sent for publication at other journals too. Active volunteers are eligible for prestigious KHA annual award. Volunteers are eligible for KHA inspirational talks. Volunteers are eligible for case discussions. KHA promote homeopathic organization as well as their mega events. KHA promote great work of speakers through their book reviews. Honorable guest may propose their future courses or event after the webinar. Ka maintain a healthy and happy environment, so keep only like-minded folks. Ka requests everyone to maintain the confidentiality of the group. For all inquiries, email us at kstudygroup@gmail.com. You can find Ka Study Group update on social media at Ka Homeopathic Study Group. Thank you. Over to you, Kavita ma'am.
Thank you so much, Dr. Nupusha. She is our enthusiastic Ka volunteer. Thank you. And thank you so much, Dr. Sweta. She manages our Ka activities with cute smile. I sincerely thank Ka Homeopathy Study Group entire team for the continuous selfless support with which we are able to make our pro bono activities and webinars so beautiful. These webinars are for educational purposes only and should not misuse any of the course content without speaker's permission. Always seek an expert homeopath for treatment. Being an outreach coordinator of CHA PR committee, HNA CPD provider encourages homeopaths to become CHA certified and to participate at HNA accredited CU webinars. For practitioners in North America, there is still time for CHC and NASH renewal. So be part of our live free study group webinars to earn continuing educational credits. Participant CU certificate. Do not miss golden opportunity to register to Enlightening Mission 5000 webinar series and LMHI 2021. More details we have posted it in the social media and newsletter. Today, November 21st, 2021, and we have our special honorable speaker, Dr. Aadil Chimthanawala, with very important topic, homeopathy in ICCU practice. We know homeopathy plays great role in addressing patients in ICCU. And when we give remedies by customizing as per the physical, mental, emotional status of the individual, we can see the results from where we use simple remedies like arnica, arsenicum, antimtar, carbovich to name few, opium, etc. to no source can be of help in this crisis. And here the cases which are presented in this webinar by Dr. Aadil Chimthanawala are his clinical cases and did receive the consent from the clients. And we planned for this session 1 hour and might extend 20 minutes more. And it is great honor to have Dr. Aadil with us today at our webinar. No introduction is needed, but for those few people, let me tell a little bit about Dr. Aadil. Dr. Aadil Chimthanawala is a well-known, experienced homeopathic doctor from Nagpur, India. After doing his MABS with honors from Nagpur University and DNP, Internal Medicine, he has completed BHMS, MD, PhD in Homeopathy, again with honors. He is the Secretary of the National Academy of Homeopathy, India. He is the world's first homeopathic cardiologist. He conducts postgraduate homeopathic residential schools twice a year, wherein homeopaths from all over the world come for training. He has delivered lectures on homeopathy in cardiology at national and international seminars at USA, Malaysia, Australia, to name few, South Africa, Singapore, Switzerland, etc. He has a very busy practice, and he also runs in Mumbai on first Saturday and Sunday, and also in Bangalore. He visits every 3 to 4 months. He teaches homeopathy at Australia, Brisbane and Melbourne and Malaysia. He is one of the pioneers in homeopathy in agriculture. He is the mentor and PG guide to postgraduate students in homeopathy by the Handyman College of Homeopathy, UK. He conducts several free health camps. And he is a famous YouTuber and has around 1,200 videos on various medical subjects to his credit. He is a Rotarian since past 13 years. And he's one of my good friend and brother. So let us welcome our honorable speaker to our webinar.
Namaskar. Assalamu alaikum. Sat Sri Akal. Thank you very much, Dr. Kavita, for a wonderful introduction. And I can see a few familiar people, Hiralalji Agrawal, Dr. Deep Narayan, Muhammad Muzammil, and many others. Few of you are seeing me for the first time, but majority, as I have seen, are my old students or they have attended somewhere or other. So without wasting much time, ladies and gentlemen, let's go to the topic today, that is homeopathy in ICCU management. Yeah. So these are the few books that are available on Amazon. Textbook of Miasms, Homeopathy Case Taking and Management, Nosod's Multipolycrest Remedies, Skin Mirror of Sick Economy, Manual on Obstetrics, on Homeopathic Gynecology and Obstetrics, and Siddhi, which are the number of drugs that we have, about 28 to 30 drugs that we have reproved, and they are available, extensive reprovings. This is the place where we work, where we are working since past 25 years. That is, I am working, and before me, my parents have been working. So what is the need for intensive care? Isaac Asimov has given a very beautiful definition. Life is pleasant. Death is peaceful. It is the transition that is difficult. And ICCU is more or less that place where this transition happens most of the time for many people. And when we see this last year and half of this year, that is COVID times, ICCU was and has played an important role. So now we are going to see certain aspects of ICCU and then homeopathy in ICCU. Intensive care, intensive therapy, intensive treatment unit, whatever you want to call ICU, ITU, or CCU, critical care unit. It's a special department of a hospital or a healthcare facility that provides intensive therapy. In fact, if you ask me, how to judge a hospital? The moment you enter the hospital, you don't have to have fancy buildings and this. You only go to the ICU or you go to the operation theater and see if the cleanliness level is very high, if the apparatus, the working apparatus are many and fully working and modern, then I would rate the hospital very high in my eyes. So intensive care therapy is a service for patients with potentially recoverable conditions who can benefit from more detailed observation. So basically, for a homeopath or even for any person, any medical practitioner, we admit patients so that we get a more detailed observation, minute-to-minute observation, hour-to-hour observation, and it is a recorded observation. That means by hours or minutes or things, we are recording the physical parameters, in our case, even the mental state, the state of disposition as it is called. Intensive care therapy basically caters to patients with severe or life-threatening disorders and illnesses, injuries that require constant care, close supervision, and life support equipments and medications to ensure normal body functions. Obviously, it is that part of the hospital where highly trained physicians and nurses who specialize in caring for critically ill patients are employed and work. And intensive care they basically distinguish from general wards by a higher staff to patient ratio and access to advanced medical resources and equipment, including homeopathy. So with this knowledge in hand, let's move forward that suppose we get a patient. Now, which patients are fit for admissions to an ICU? People whose diagnosis is suspected or confirmed, and suspected or confirmed to be a bad diagnosis, not prognosis I'm talking about, a bad diagnosis. That means the sickness has evolved to a level where the life is being threatened. The severity of illness, age now basically in adults ICU, and in pediatric population it's PICU. Coexisting diseases, physiological reserve, very, very important, what we call as vital force, the vitality of the patient, physiological reserve. That includes blood pressure, pulse, temperature, respiration, etc. Prognosis of the disease, an immediate prognosis and a long-term prognosis. Availability of suitable treatment. You can admit people to ICCU, but then provided you have a suitable treatment for him or her in the ICU. Response to treatment till date. Suppose if the patient has been sick for a long time, severely sick for a long time, how was his or her response to the previous treatment, so that now you need to shift the patient to an ICU. Recent cardiopulmonary arrest, unless otherwise approved, needs ICU admission. Anticipated quality of life. If you know that the quality of life is not good, if the patient is going to stay but quality is like vegetable, there's so many cases who go into deep coma, and you know that it's not like for a week, maximum 20 days, 30 days, okay, but then thereafter you know that the patient is not going to come out. So is it wise to keep the patient in ICU? And the patient's wishes. There are many times patients do wish themselves to get admitted to an ICU, so that needs to be honored as medical professionals. So these are few factors wherein we admit patients to an ICU. The basic monitoring requirements in ICU should be the heart rate, first thing, blood pressure, respiratory rate, pulse oximetry. Nowadays, initially, this pulse oximetry was the domain of only ICU, but after COVID, it has become a household name, pulse oximetry, and probably half of the world must be owning this pulse oximeter. Hourly urine output, temperature, and blood gases if needed. So these are the basic monitoring requirements if a homeopath wishes to set up an ICU. These are their legal requirements as well. Now, difficulties in handling emergencies. I doubt very much, like I don't know myself how many homeopaths actually own an ICU and actually work exclusively with homeopathy in ICU. But many homeopaths, particularly at the level of students or new interns or those of newly started practice. So what they do is morning time or afternoon time, they give to an ICU, and evening time and rest of the time they devote to their own personal clinics. So, and many of us, of course, I have an ICU, that's a different thing, but many of I am called, and many of us are called in an ICU to treat emergencies. So an ICU, that means a ICU belonging to another hospital. So what problems come is there's no formal practical training for managing emergencies for homeopath. In fact, nowadays, modern medicine has a special intensivist. The word intensivist is there. They receive special training for a long time to handle patients in ICU. Of course, that is at the basic MD level, and then thereafter. But in homeopathy, there is no formal practical training for managing emergencies. Remedies not proved to the level of biochemical and pathological changes. We have around 3,000 to 4,000 remedies in Amatemedica, and hardly hardly at all the remedies are proved to the level of biochemical pathological changes, which is a very great advantage of modern medicine, material doses, wherein they are proved that way. Our remedies, the prescription of remedies is based on clinical symptoms and observations at the best. Now, for us, the drug selection becomes very difficult since the time is less. A homeopath is called to manage an emergencies when everything else is failed. B, the patient is an old patient of homeopath, or the relatives are or the friends of the patients are taking homeopathy from some senior homeopath, and they desperately want help. So they come with very high hopes, one, and they come at the last moment, two. So time is less and the settings are artificial, meaning thereby that already the patient is on so many drugs. Second, for example, let's all ICCUs are air conditioned. So we don't know whether the original patient is perspiring or not perspiring. Let's take a simple example of perspiration. We'll not be able to know because the settings are very artificial. There are few or no natural symptoms to prescribe upon. Patient is already on many allopathic medications. We don't get the full case only for a particular symptom. And in maximum settings, at least in India, maximum places, the relatives go to the OPD of homeopath, tell them ABCD symptoms, what they know of the patient who is in the ICU, and only on those basic symptoms the homeopath gives medicines, and it's just a trial and error whether the patient comes out or not. And it's a very, very big achievement if the patient actually gets the medicine in the ICU, because most of the hospitals bar any other external medications in an ICU. Yet we are talking about this subject because there are so many places where you can give. So always not negative things, it's positive also, and homeopathy can actually turn the game. I'll give you a case which I recently presented last week in one of the seminars. Again, I'll present it today. It's a recent case. The patient is already on many allopathic medications. We don't get the full case because there's hardly any time. Only for a particular symptom we have to prescribe upon. Homeopathic help is sought when the pathology is advanced and allopathy has failed to act. So these are very common difficulties, and now how to handle those difficulties we'll see. Now let's see, at least when we're talking about India, because India has a legal degree, BHMS. I don't know about other countries, but BHMS or register is a registered medical practitioner. Initially, a BHMS was not a RMP, but now with the amendments, BHMS is a registered medical practitioner. And that is why a BHMS holds all rights and privileges of a registered medical practitioner. It's a valid qualification for handling all emergencies in using tools and homeopathic remedies. Using tools, thereby I mean, if you know how to put a patient on a ventilator, then you can do that. If you know how to conduct a dialysis, then you can do that. If you know how to insert an IV line, you can do that. If you know how to insert a central line, you can do that. If you can give a cardiorespiratory massage, you can do that. So all emergency tools can be handled by a homeopath, a registered medical practitioner. A BHMS can issue a death certificate, a valid death certificate in India, and that will be valid. Initially, this was not the case, and that's why this was a prerogative only of MBBS and postgraduates in modern medicine. And legal issues, BHMS is governed by Consumer Protection Act. So homeopaths are governed by Consumer Protection Act. That means you have to be very, very, when you're handling patients in ICU, you should keep your paperwork intact. ICU has to be registered at the local municipal corporation. Suppose nowadays many people, many young homeopaths who are bold enough, they have worked in an ICU say for 3 years, 5 years, and now they are ready. they know that they can handle patients. So they start opening up an ICU. So, but that ICU has to be registered separately. That means apart from your hospital, an ICU also has to be registered at the local municipal corporation. A consent form is important. Suppose if you are called for homeopathic consultation in an ICU, or you own an ICU, every time, like a surgeon before the surgery, a serious patient or his or her relatives before the homeopathic treatment should sign on a consent form. Notes and investigations should be very well properly maintained in legible handwriting or in computerized form. The bills and prescriptions should also be, and nowadays homeopathic prescriptions are recognized by loads of companies and insurance agencies for the claims. So bills and prescriptions have to be very well managed. This is now not required in OPD setting, but in ICU setting, it is very much valid. Communication with relatives regarding unnecessary claims. So this is a very important thing. In fact, outside the ICU, one communication chamber or the patient's chamber should be there, wherein immediately after the assessment of an intensive care, a patient who's brought in the ICU, what is your take? How are you going to go ahead? Whether the relatives still want to continue with you, that needs to be told to the relatives. And after you tell them, take the consent in writing that whatever I've spoken, either record them, because this ICU has a very high legal prerogative. And that's why many people shun doing ICU practice. There is no legal literature of homeopathy for diagnosis. Like, suppose if a homeopath is asked for diagnosis, we are obviously supposed to do a nosological diagnosis that I am treating a patient of angina pectoris or a myocardial infarction, that nosological diagnosis. Second, I have to do a drug diagnosis, an acute drug diagnosis. I have to do a miasmatic diagnosis. So all these three diagnoses are important for me. As far as for modern medicine, it's just the disease diagnosis and the investigations can help, but not for me. For homeopath, the three diagnoses are important and it's up to me how to go ahead. But there's no legal literature of homeopathy. The court of law does not know that there is something in homeopathy, such diagnoses are relevant in homeopathy. What is miasm? Nothing is known. That's our fault. At least in India, it's our fault because we have not been, in spite of having so many homeopaths, the largest homeopathic community in the world, practicing community in the world, practically every single suburb in every town and village and city has a homeopath, whether he or she is practicing homeopathy or that's a different thing, but BHMS people are practicing. And yet, Indian constitution, the fine technicalities of homeopathy are still not available in legal books. Another very important thing which I came to know after talking to many people for long back, of course, again, in legal matters, when a homeopath is supposed tried in the court of law for certain issues, the expert panel should be ideally constituted by a homeopath, by the team of homeopaths, other senior homeopaths of the city or of the country, whatever. But when a homeopath is put on trial, doctors from other streams take, like Ayush now. So Ayush mainly is BAMS. It should be considered for all Ayurvedic, Unani, and homeopathy, etc. But when we are talking about expert panels in legal matters, 70 to 80% of the panel generally is from doctors or experts from other field than homeopaths. This is not the case when a person of modern medicine is put into on a trial for the same reason. So that again needs to be amended, and homeopaths should take a lead for doing that. Having said that, Just a minute. Yeah. Having said that, is there anything mentioned in the literatures by Hahnemann which gives us a free hand to use the so-called auxiliary measures? Yes. So non-medicinal aids or tools which are administered or applied to the sick along with or without remedial agents. Actually, ICCU is 90% auxiliary measures, non-medicinal aids or tools, and only 5 to 10% actual medicines. Even I'm talking about modern, the regular ICU. So these you have to master. If you want to enter such type of practice, we need to master auxiliary measures and their effective usage at that period of time. So non-medicinal aids or tools that are administered or applied to the sick along with or without medicines. The essential modes of case management. And if you read the footnote of aphorism number 67, as well as aphorism numbers 288 to 294, Hahnemann has given, of course, that knowledge that was there prevalent in his times, but then you can extrapolate to the same knowledge and today in 2021. But footnote to aphorism number 67 in 5th edition of Organon clearly gives us permission that to save a life, use of auxiliary measures are permissible by homeopaths. So Dr. Hahnemann himself has given you a full permission as far as a saving of life is concerned, or in critical cases or intensive cases or non-miasmatic cases, you can freely use auxiliary measures. But auxiliary measures do not mean that you start using allopathic drugs. Drugs should be homeopathy. Auxiliary measures like, as I said, dialysis or a ventilator or IV fluids or giving blood to the person who needs blood, that is permissible. So the objectives basically are auxiliary measures as well as the person handling patients in ICU is to save life in life-endangering conditions. Assist the curative process in natural relapsing cases. There are so many times, we'll see in the second last slide, wherein I've talked that we get patients, there are 3 types of patients available for homeopath. Number 1 is a newly diagnosed case. Okay, newly diagnosed emergency who's come to us first time in his or her life, and that has to be handled by homeopath. A second case would be a person who's already on constitutional homeopathic management and has a severe unwarranted homeopathic aggravation which has landed him or her in an emergency. Now this is quite unique to a homeopath because here homeopaths are managing emergencies because of homeopathic drugs. Assist the curative process, natural and relapsing cases, to relieve the distress like excessive pain, excessive dyspnea or breathlessness, fever, bleeding, etc. Alleviate or decrease indispositions like food poisonings or overeating. Of course, these people don't get admitted in the critical care unit, but some people might, like they may think that simple acidity has become a heart attack, and even the homeopath may be thinking that, so they may accidentally come into the ICCU. Rehabilitation, post-paralysis, post-operative, post-traumatic, and as preventive, that these two don't need ICU therapy, but still, this is a job of homeopath to rehabilitate, and we can use homeopathy, and as preventives you can use yoga, relaxation exercises, that is auxiliary measures. So life endangering cases, there are many. Now since I deal only with cardiology, that's why I'm showing this slide. Otherwise it can go on and on. So acute left ventricular failure is the most severest form of medical emergency you get in a cardiac case. shock, strokes, spinal fractures, head injuries, cardiovascular failure, respiratory failure, and hepatorenal failure. These are life-endangering cases, and you have to follow the rule of A, B, C, D, E. A is airway, mouth-to-mouth resuscitation, airway insertion. That has got no parallel, no, it has to be done. Breathing, loosen the clothing, clear the oropharynx, suction oral or nasal cavity, and diaphragmatic pressure. Circulation, for establishing circulation, you have to give a cardiac massage at the rate of 40 per minute or 1:4. Respiration is to massage. That is at this site. That is when you are handling the patient of hospital or of an ICCU. Patients yet not come to the ICCU. But in the hospital, you have got the DC cardioversion. You should be able to use DC cardioversion. That's why homeopaths should nowadays in the BHMS itself, or at least in MD, particularly those who are doing MD in practice of medicine, they need to be taught cardioversion, and it should be done at the rate of 220 to 360 joules as and when required. Dextrose 25% can be given IV or in small children intraumbilical. Intracardiac or IV adrenaline. Now, since I am doubly qualified, so that's why I've written that, but then that is not done with should not be done with the homeopath, but with permission you can do, because in states like in a state like Maharashtra, there is a course allowed by the government of Maharashtra. It's a 2-year course, or I don't know how many months course, but wherein homeopaths go to the medical college, proper allopathic medical college, and get trained to manage ICCU, critical care patients. So they are trained to how use these emergency drugs, like giving intracardiac or IV adrenaline, ventilator if it is needed, draping, endotracheal intubation, and protection of parts. Now, many people must have seen this protocol, because time and again, there's so many protocols I've prepared, right from chest discomfort to myocardial infarction because I may not be there in the ICCU 24/7. My associates are there, my interns are there, people handling. So their materia medica, their repertorization is not as good as me. So to help an easy selection of drugs, that's why these protocols are made. I believe that you also should try these protocols in your own clinic. They're very easy to try. The only question remains is the potency here, which is not mentioned, but you'll be surprised that opium can manage angina as well as cactus. Because normally if you ask, like we are talking, suppose we are talking about chest discomfort. This ESA protocol is meant for chest discomfort. The first drug that comes to the homeopath's mind is cactus or craticus or naja or spigelia or lactis at the most. They don't go beyond these 5 drugs when faced with an emergency. Whereas I want you to use Bryonia, Naxomica, Aconite and Naja, Ignitia and Gelsemium, Ceres Bonplandia and Colosin with equal efficacy as cactus. That's why these drugs were always in the backdrop. They were never in the forefront of managing angina. And we know in homeopathy that each drug is quite unique, and the indications of those drugs, if they are met, then there is no other alternative. There should not be other alternative. Although we may get for a particular symptom many drugs in the repertory, but then to close them down in an emergency situation where the time limit is very less, that's the reason why these protocols have been made. About 20 to 25 protocols are there. I have written a book. I've written a book on a textbook of homeopathic cardiology, which will soon be published, wherein all these protocols, hypertension protocol, chest discomfort protocol, myocardial infarction protocol, congestive cardiac failure protocol, arrhythmias protocol, there's tachyarrhythmias and bradyarrhythmias, different, then pulmonary hypertension protocol, and so on and so forth. They are mentioned in depth, and the reason for they're not just bookish knowledge. These are based on multiple experiments. You have given them multiple patients in different types of different potencies, and then we have come to this scenario. So ISRA protocol, E is exciting factor, S is site, R is radiation, and A is associated symptom. So suppose when a patient of chest pain comes to me for whatever reason, let's say angina pectoris, I take out an ECG. If I know how to read and diagnose, very well and good. If not, then I may go on to take out an echocardiogram. But then ultimately, if I have to select a remedy, it will be on the reason for the chest pain. Why has this patient brought this chest pain? If it's because of an anger issue, that means the patient was angry and the patient fought with the other person, and yet with that anger inside has brought chest pain, the drug would be bryonia. If the patient could not express, could not fight, could not release the anger, and that's why the chest pain has come, it's colocynth. If the patient has been insulted, patient also has insulted the person who has insulted him or her, and yet has chest pain, it's nux vomica. It was non-expressive insult, it's staphysig area. If it was because of some fear, expressive fear, aconitis naja, and non-expressive fear was opium. Grief, if it's an expressive grief, it's ignitia. Non-expressive grief is acid phos. Ailments from bad news, if it was expressive, gelsemium. Non-expressive, chamomilla. Ailments from joy, I've got so many cases that after joy, they start getting chest pain. On many people have got amines. So, I mean, when you read in Matra Medica, and when you actually get such patients and you give those drugs and it acts, then you know that you have to salute these people, Kent and Hahnemann and all these famous people who have brought these symptoms into practice homeopathy. That yes, ailments from joy is a very, very important symptom. Expressive, it's Ceres bonplandi, and non-expressive is cough. But many people will not have an emotional issue. Some will say that after having meals, I get chest pain. So I have to have very small meals. Moment I have a heavy meal, a little bit heavy meal, I start getting chest pain. And in fact, it's a dictum that once you're diagnosed with myocardial infarction or you have an unstable angina, you are not supposed to eat full stomach, because 95% of cases, a heart attack comes on a full stomach. The reasons are there, but this is not the time and the place for mentioning those reasons. But some people get chest pain by walking on a straight road. Then the remedy is again bryonia or spigelia. And some people have only on ascending steps, which is coca. So coca patient can walk freely straight, but they will not have chest pain. Same way, a bryonia or spigelia requiring patient can climb up steps and they will not have. Now, this is a paradox, but this is seen very well in clinical practice. Many people have post-coital angina pectoris, very well known, and the remedy of choice is nux vomica. But then sometimes you don't get, how much have you asked the patient? No, sir, nothing has happened. No anger, no insult, no eating, no walking. I am getting chest pain. So then what to do? Then you shift to the next part of the slide. Okay, where is your chest pain? If it's localized on the left side of chest along with palpitations, then it's spigelia. If it's left chest to the left arm along with ghabrat, now this ghabrat is a uniquely Hindi word. It is, you can at the most call it restlessness, or restlessness inside the chest. A sensation which cannot be described by the patient. Doctor, I don't know what is happening. It is not pain. It is something which I can't describe. It is happening here. I am not overall restless, but this area, this is something I don't know, I can't describe. Now, these words, we call it in Hindi as ghabrat. So left chest to the left arm ghabrat is arnica. And my dear friends, arnica, according to me, is the sorbitrate of homeopathy. That means if you don't know anything about managing heart attacks or angina pectoris, arnica can be freely given in high potency and repeated often, and you will see that your chest pain goes down. This is the best alternative and very easily available. It's very commonly used. Left chest to the back, a very, very common phenomena nowadays with diabetics particularly. they have got chest pain, which radiates to the back. And the remedy of choice is Latrodactylus mac, a spider remedy. Left chest to the left jaw, along with choking, it is Naja. Left chest to only the throat here, along with, again, intense restlessness. It is not breathlessness, it's restlessness here and here. Then it's cactus or arsenic. Many people, particularly those suffering from right coronary artery. Now, we have got two coronary arteries, each individual, normal human being, left and right coronary artery. The left coronary artery, after going from a certain distance, divides into two parts. The left anterior descending, which supplies the apex of the heart, and the left circumflex, which supplies the interventricular septum. And the right coronary artery, in 70% of patients, supplies rest of the heart. Now, what we have seen in diabetics, particularly young diabetics in India, because India happens to be the world capital of diabetes, we get a lot of cardiovascular complications of diabetes. And one of the complications is an early MI, early myocardial infarction. So what we see is these people generally have a blockage in the right coronary artery. And one of the chief symptoms is the pain starting from the left chest to the back. And this entire area becomes numb. And for a pretty long time, they call it cervical spondylosis. They call it spasm of the trapezius. And then it stays for some time. You massage it and then the thing goes away. So to keep on ignoring it. Actually, it is angina pectoris. One should take a treadmill test, not an ECG. ECG would always give you normal report. Not always, but can give you most of the time normal report. So left chest to jaw, choking. Now, another feature of diabetes and heart disease, diabetes and MI, is right chest to the right arm. The pain starts in the right chest and radiates to the right arm. That is Lilium tick. This is very common. Or right chest to the right jaw. It is McFoss. Sometimes the chest pain or chest discomfort is not that much predominant. It is slightly there, but sweating is profuse. Then the drug of choice is camphor. Many times patient complains of pain, slight chest discomfort with extreme acidity. That means burning. It may not be hyperacidity, it is actually MI, or it is actually inferior ischemia. The remedy of choice is Nux vomica. So Nux vomica happens to be the next best remedy to be for heart patients, to be used for heart patients. Especially in managing chest pain and myocardial infarction. Pain with excess flatulence is diascoria. Now, however good your mathematica may be, but at that point of time, to think about diascoria is absolutely. Now, suppose if you have this chart in your clinic and you have to just see and verify it, I think many of the people would start using these. Now, if you have got, I would normally want that you use the highest available potency, 1M or 10M plus. I use 0/1, 0/2 LM potency, but everywhere LM potency is not available. Many people are not proficient in using LM potencies. That's a different matter. So you should. Now, if you want to use LM potencies, start with LM 0/1, then jump to 0/3, 0/6, 0/10. Don't keep on increasing 0/1. Keep on repeating that. If it's showing results, go on. Now, a case. This is a part. This case has got two parts. One is an emergency part. Unfortunately, it's in Hindi and it's by a doctor. He's a homeopath himself who got a heart attack and it was managed with homeopathy. And then a chronic, the same case after the ICCU, he was discharged from the ICCU. Then how we managed the, this is given in my YouTube channel. This video has been uploaded in my YouTube channel. You can see that, but it's in Hindi. Unfortunately, there are no English translations, but then I will show you the case later on, the full case.
Good morning. Dr. Satyanarayan.
Can you hear it?
Homeopath practicing last 10 years. Last year,
Voice?
is December 2024. Chest pain.
Is the voice
Yes,
audible?
Dr. Aadil. Yes, we
Thank
can
you.
hear.
Stress because of financial issues, lockdown में stress था. इसके बाद में मुझे इसी वजह से क्लिनिक वगैरह नहीं चलने की वजह से थोड़ा स्ट्रेस होने की वजह से रूटीन काम में एक दिन सडनली मुझे स्टेयरकेस चलते वक्त चेस्ट पेन होने लगा। तो इट वाज लाइक टिपिकल चेस्ट पेन, रिट्रोस्टर्नल स्टेयर्स से रेडिएटेड टू लेफ्ट आर्म। उसके बाद में मैं इमरजेंसी में हॉस्पिटल में गया। उन्होंने ईसीजी निकाला, ईसीजी वाज वेरी बैड। उन्होंने बोला कि आप तो ताबड़तोड़ आप अपोलो में एडमिट हो जाइए। बैड इन द सेंस कि हार्ट अटैक आया था उस टाइम, बहुत हार्ट अटैक मींस ऑलमोस्ट हार्ट अटैक भी आ गया था। अच्छा, ईसीजी में बता रहे थे। ओके, तो उन्होंने बोला कि आपको ताबड़तोड़ जाके एंजियोग्राफी करके फर्दर ट्रीटमेंट करना है। तो हम अपोलो में गए उसी दिन सेम डे 20 दिसंबर 2020 को। फिर वहाँ पे एंजियोग्राफी किया। एंजियोग्राफी में बताया गया कि मेरा ट्रिपल वेसल ब्लॉकेजेस है अराउंड 90% स्टीनोसिस और ईएफ मेरा इंजेक्शन फ्रैक्शन जस्ट 55% है। मतलब पंपिंग कैपेसिटी 55% आ गया। 55% आ गया, ठीक है। फिर उन्होंने जो बेसिक ट्रीटमेंट दिया होगा वो दिया। हाँ, वो दिया। उन्होंने बोला कि इमरजेंसी आपको एंजियोप्लास्टी करवाना होगा। ओके, नहीं तो आपको आज ही रात में कुछ हो जाएगा। ओके, तो फिर हमने सर से एक बार बात किया। सर ने मुझे ऑनलाइन कंसल्टेशन उस टाइम दिए। तो उस टाइम से मेडिसिन स्टार्ट कर दिया। तो सर ने बोला कि मुझे यहाँ पे आने के लिए, लेकिन बिकॉज ऑफ सम इशू में नहीं आ पाया। लेकिन जो मेडिसिन सर ने दिए थे वो सब मैं कंटिन्यू रेगुलरली लेते रहा। उसके बाद में मैं 6 महीने के बाद यहाँ पे जस्ट लास्ट मंथ ही आया, जून 2021 को आया था। नहीं सर, वो स्टार्टिंग 3-4 दिन जो कंसल्टेशन था, हाँ, तब आया था। तो सर ने मुझे मेडिसिन दिए और आफ्टर 1 मंथ में मुझे 80 to 85%, 90% बोल सकते हैं, बहुत सिम्टम चला गया। पेन नहीं होता है। जब आते थे तब, जब आए थे फर्स्ट टाइम तब 1 महीने पहले, तब सिम्टम्स थे क्या? हाँ सर, तभी बहुत सिम्टम था। इनफैक्ट मैंने उसी से पहले आधे घंटे पहले यहाँ पे बोला कि ईसीजी का ये है। हाँ, वहाँ से ईसीजी निकाला था ये, जो कि अभी दिखा। ये पूरा ईसीजी था एंड इसके अंदर अभी आफ्टर 6 months ऑफ अटैक पूरे चेंजेस थे। जो एरोस दिख रहे हैं पूरे चेंजेस थे। एंड आज सुबह का ईसीजी निकाला है, निकल का इज एब्सोल्युटली नॉर्मल। उतना ही नहीं, कल का ही इको है। तो लास्ट इको का रिपोर्ट वाज 55% पंपिंग कैपेसिटी, दिस हैज कम टू 72% ओनली इन 1 month। तो सिमिलरली होम्योपैथी करेक्ट मेडिसिन देने से, नाउ ऑफ कोर्स एंजियोग्राफी करने से वी कैन कम टू नो द एग्जैक्ट स्टेटस ऑफ द ब्लॉकेज। लेकिन इको में इतना चेंजेस एंड सिम्प्टोमेटिकली पेशेंट इज मच बेटर। गुड मॉर्निंग।
So, this same case, he's a 38 years old male gentleman. He's basically a homeopathic practitioner. He reported to us in June 2021 with complaints of pain in the left chest, radiating to the left arm, aggravated by physical exertion, easy fatigue, excessive belching and flatulence. His appetite, urine, sweating were normal. Basically, he desired sweets 3+. Stool was loose and occasional mucus, he used to pass occasional mucus in stools. Mentally, a very nervous person, apprehensive person, and he was depressed, particularly in the entire 2020 and 2021, when other doctors had booming practice. This gentleman's practice was not good, so he had a very great financial burden. But on the top of that, on the day of the heart attack, he had received another bad news, and that bad news was relating again to the financial crisis. Something had happened, and then he did not know how to go ahead, and he brought a heart attack. So that was on the day when he got a chest pain. Okay, so basically a nervous, apprehensive person. He had got ailments from long continued mental stress, of course mainly financial, and a very impulsive person in making decisions. Past history was already hypertensive since past 5 years and on a drug called telmisartan. He was also diabetic on metformin and ischemic heart disease. That means he had a chronic stable angina since 1 year, which he was neglecting. He had not taken any medications, homeopathy or otherwise, and he was still continuing with it. And eventually, he landed up in a heart attack in December 2020. No particular family history to be mentioned. When he had come to us, that is in June 2021, his pulse was a little bit high, tachycardia of 96 per minute, BP was 170/100 in spite of taking telmisartan, and other systemic examination were normal. Now, when he was in the ICCU, his wife called me up because they know me he's my student, so he knows me very well. So his wife reported on the phone, and he was prompting from the ICCU bed. There was sudden onset soreness in the left chest, radiating to the left arm, and better by constant motion. That means he wanted to walk. Unfortunately, in an ICCU, you can't keep on walking, but then that's what he wanted. And I had asked him why, what had happened suddenly? Why did this man land up in an ICCU? I asked his wife. So his wife said that he had a sudden financial loss on the ongoing financial crisis, which he was already facing. And that was a very bad news, and that led to a heart attack. And I asked her, there was a video call, so I could see him. He was very depressed. He wanted to be by himself. He wanted to be alone. And normally in such a state of agony, you want to be with your loved ones. That's a different thing. But then this man, he wanted to be alone. He was very much depressed. And the BP was 190 by 104 millimeters mercury when he called me. That was a time when he was just getting admitted to the ICCU. And so from his home itself, he called me, and then the phone got cut off. And then again, when they reached the ICCU, so this was the time. So he was hospitalized at a private hospital. His angiography was done, and it revealed triple vessel disease. A rescue angioplasty. That means whenever a patient with a heart attack comes, a young patient with heart attack, we would, many doctors directly go in for primary angioplasty, so that the occluded vessel, the immediate occluded vessel, is freed of the clot, so that the blood supply starts and the patient's life is saved, and the pumping capacity of the heart does not go down, because sometimes thrombolysis also fails. So he rescue PTCA was advised but not done. He was not even thrombolized because he reached the ICCU quite late. He started having an attack quite early, but when he reached the ICCU, it was quite late. So the initial hour, the golden hours where he could be thrombolized, had passed by. We gave him gelcemium 1M, repeated every 30 minutes till the patient settled. And this, my dear friends, actually helped him. These are his words, not mine. So that we could take, they could such a bold step that rescue PTCA and thrombolysis were avoided. This was the ECG. Unfortunately, this is not a very beautiful, good ECG, but you can see ischemia changes quite very well. An angiogram was done. Left main, short and normal. LAD, type 3 vessel with subostial 90% stenotic lesion, followed by 90% stenotic lesion in the mid segment. So each vessel is divided into 3 parts: the proximal segment, a mid segment, and a distal segment. So proximal segment here got 90% in left anterior descending artery, and the mid segment also had got 90% stenosis. Then left circumflex, another artery, was the dominant vessel with total occlusion from mid segment. Now, normally in 70% patients, I say in normal people, the right coronary artery is the dominant vessel, but in this patient, it was left circumflex, which is the dominant vessel, and that is completely total occlusion from mid segment downwards. Major marginal shows diffusely disease. So the left circumflex gives out marginal branches. In this case, were totally occluded again. The right coronary artery was a non-dominant vessel, and you can see LVEF 55% on 2D echo. Okay, so this was the state, and that's why we had given an acute state gelcemium. But when he come to me in June, after 6 months, symptoms for constitutional semiluminum, ailments from long continued mental stress, hurried person, apprehensive, impulsive, desire sweets, eructation, flatulence. You don't need a repertory for this case. Argentine nitricum 201 stat, and repeated after 15 days. Extensive lifestyle changes, blood group diet. That is the diet which I advise all my patients. Exercises and meditation. After 1 month, you could hear, those who understand Hindi, they could see that no symptoms, ECG normal, 2D echo, the pumping capacity came to 72%, from 55% to 72%, hardly in 1 month. That's actually an achievement. So I've shown you, although my topic is ICCU today, so the ICCU, when he was admitted, we could avoid a rescue PTCA, which is a very costly thing in today's times. This was the ECG in June, and 2D echo, you can see the second line, LVEF is 72%. Left ventricular cavity and walls are normal. LVEF is 72%. RV is normal. Rest everything is normal. So echocardiographic Doppler is normal. So it's a classic case of acute coronary syndrome in young diabetic, commonest presentation nowadays, at least in India. Gelsemic was an acute civillimum, helped him settle down to an extent that he was not thrombolized, neither had anything happened to him after refusing rescue PDCA to LAD. Now, this is a very case-wise decision. You please do not generalize it that with every homeopathy medicine you can avoid these things. No, I don't generalize, but in this case it happened, and he was lucky that nothing had to be done forward. And argentum nitricum was a constitutional civillimum. Not only is he symptomatically better, but his ejection fractions increased from 55 to 72%. Another short case, a 53 years old male hospitalized at Shad. That Shad is the hospital, which the photograph which we saw on 23/1/2021. That is in January, with breathlessness aggravated by walking since 3 months, generalized dropsy or swelling since 1 month, and nocturnal cough which was dry, aggravated by inhaling. He wanted slow fan when he was admitted at my place. There was no chest pain, no bowel complaints, urine was very less, appetite was less, thirst was less, sweating was profuse. According to the history given when the patient was admitted, he had got no diabetes, ischemic heart disease, no tuberculosis, no hypertension, that means he was completely normal. This was the first time he was ever admitted or he had ever had any symptoms. That is 23/1. On examination, he had a dull look, pale waxy face, anasarca, that was generalized bloating. Pulse was unusually high, 148 per minute, irregular missed beats. BP was low, 100/68. High JVP, liver was palpable, and S1, S2 was normal, but there was an S4 gallop. Now, what do you mean by S4 gallop? Normally, if you put a stethoscope on the chest, which I do, I still follow the battery is low. Follow the old method. I still examine patients. So, whenever you get on stethoscope, that means there is a gallop, and it means heart has failed. Respiration was few repetitions per present. So this was a tachycardia, old anterior wall MI, global T wave inversion, and on echo, his ejection fraction or pumping capacity was 30%, and he had global hypokinesia. Hypo means less, and kinesia means movement. So movement of the wall was very less, and that means he had got multiple heart attacks earlier, but this gentleman did not know that he had a heart attack. Anyway, we did his investigations, and on repertorization gave China. There were digitalis, acetic acid, and arsenic alb. We started with, and we diagnosed him as case of ischemic cardiomyopathy. That is, multiple times ischemia had taken place, and the ejection fraction had come down. So cardiomyopathy. We started with China 0/1 every 2 hourly, along with oxygen support and a propped up position. By 24/1, breathlessness was better, and the cough along with sputum started. He had dry cough, but now cough with sputum started. We increased the potency China 0/2. By 25/1, patient was better, swelling decreased, urine output was slightly better, China 0/2 TDS, oxygen as and when required. By 27/1, China 0/3, 28/1, China 0/3 once a day, and then on 2nd February, he was discharged. He is still continuing a therapy and is well. Untreated infarcts, there's a greater chance of congestive cardiac failure. Suppose, and this happens in diabetics. Diabetics do not experience pain. So they keep on getting heart attacks and they don't know. Minor heart attacks and they don't know they have got a heart attack, and that's why ultimately the heart starts failing. We followed a CCF protocol, and the remedy was China. In China, when you see, now China, when you see the Mathematica, suffocative attacks aggravated on walking, cardiac dropsy, mentally the patient was very irritable, very sensitive, hurts others' feelings. This is very classical. Not only sepia hurts others, the loved ones, but China also hurts others. The words of China, in particularly when the patient is not as a person, but as a patient, very, very rude. Lycopodium, China, sepia, they're very rude people. So hurts others' feelings. This was there with the patient. Dull look, pale waxy face, strong heart, rapid irregular pulse. He had got ventricular tachycardia, and that's why China was given. You have to compare it with digitalis, wherein the pulse is irregular but very slow, very weak, and a dilated heart. Dilated heart was there even in China, this person. Cough with bloody spotty mucus. There was no blood in this patient, in the sputum. Anxious about the future, fear of suffocation at night, dull and lethargic. It's there in digitalis. Our patient fitted China and in an ICCU was managed very well with China and came out very well and still is good. Now, since the time is less, certain points need to be known when you're handling patients in an ICU. Carcinosin, use of nosodes is extremely important. Carcinosin retards the downfall of any clinical condition. Not only, I'm talking like, for example, a heart attack, the patient's pain is not going, you don't know what to do. Or BP is not coming up, or you have tried your very level best, you're not getting any results. Give a dose of carcinosin 1 mg and it will retard the downfall of clinical condition, brings back the vital parameters like the blood pressure, the sugar levels, etc. Many people don't use medurinum in shock, but friends, when Viratriptan valve or Carbovich fails, in shock, think of medurinum in high potency. And in incessant cough, when the patient is continuously coughing, you have tried mephitis, you have tried spongia, you have tried hyoscyamus and drosera and Bryonia and Rumex, and nothing is acting. Even on OPD cases, use medurinum and you'll find fantastic results. Cifilinum is a fantastic remedy for unstable angina, even peri-infarct angina, and particularly when the patient cannot bear the pain. In spite of nitrates, the patient is getting pain. Give cifilinum, high potencies. Pyrogen, obviously, fever with tachycardia. So pyrogen cannot be used in dengue, typhoid, and hepatitis. Because in dengue, typhoid, and hepatitis, you get slow bradycardia with fever. Rest, all fevers will present with fever with tachycardia. Cecal core is generally used in emergencies where there are large bloody bulla, throbbing pain in necrotic areas to halt and reverse the necrosis. Staphylococcin, a fantastic remedy, should be used very often in ICCU. Don't restrict yourself to pyrogen only. If staphylococcus is proved in the culture, go for staphylococcin. It halts staphylococci infections. You may call it as isopathy, whatever you want to call, but staphylococcin helps a great deal, so as with streptococcin. Sorinum stops viral itching and exfoliation, and anthracinum halts fast-spreading suppuration, especially in diabetics. And now, anthracinum was the drug of choice in most of the patients of mucormycosis that had present after COVID infection. Many people have received anthracinum at my clinic, and they have done superbly well. Again, last slide. Opium, when the best selected remedy, acute remedy fails. You have given antimtar for some reason and it's not acting. What do? Just give 1 dose of opium. Antimtar, pneumonia of any type, particular pulmonary edema. Carbovich in hypoxia and asphyxia. Nux vomica, acute inferior wall MI and pancreatitis. Arsenic, when there's profuse vomiting due to any cause, acute anterior wall MI and left ventricular failure. Now, arsenic has got hypertension with MI, whereas Carbovich has got hypotension with MI. Apis for generalized swelling. Aspergillus sperma for breathlessness, congestive cardiac failure. Phosphorus for external or open system bleeding. Lachesis for intracranial bleeds. Tarantula cubens, not hispanica, for cancer pains. And sulfur for pyrexia of unknown origin. So these are drugs which gets you along and helps you deal with an ICCU patient. So dear friends, thank you very much for patient hearing, and I'm ready for your questions. Any questions, please?
Dr. Sweta, you are muted.
Yes, ma'am. Sir, first question is from Dr. Hira Agrawal. What is the meaning of blood group diet?
There's no meaning of blood group diet. Many people keep on inventing new diets day in and day out. What we've saw since we're practicing since 2008 is a diet which is based on the blood group type, even exercises. And this is very helpful in cardiac patients. When you're managing metabolic disorders, then it's very, very essential that the diet should be correct. Now, which diet is correct? Allopaths will say that don't eat saturated fatty acids and don't do this, and there's so many things, but patient compliance is extremely less. They do for 1 month, 2 months, 3 months, and then fizzle off. And if the diet is not proper, then you can't handle metabolic emergencies and metabolic diseases. So that's why we devised a diet. It is a so based on the blood group, which blood group, for example, O positive, they don't do well with milk. So if a person is O positive, you stop milk and milk products. You stop wheat. Just by doing these two things, a lot of symptoms like gastric symptoms and allergies, etc., can be taken care of without medications. Now, so what's wrong with that? So likewise, A, B, and O, positive and negative, different diets we planned. Many we experimented, failed, then tried again, and ultimately we have a good set. Same with exercises. There are many patients who complain, doctor, I walk 6 kilometers a day, and yet for the past 3 years, my weight does not increase. Weight does not decrease, sorry. So what to do? So then again, your diet is there. If you're B positive, if you keep on walking, nothing's going to happen. You have to exercise. Which exercise are you going to do? Are you going to play racket games, or you're going to do yoga, or you're going to do gym exercises? So which is good for you? So according to diet, so that has helped us tremendously. And you could see in this one patient itself, the case which I had shown, you could see how you have the actual testimony and of here, not only drugs. So it's not it has to be a holistic approach. So that holistic approach also includes the drug, the diet, and the exercise. And in our case, we prescribe according to the blood group, blood type.
Next question is, any specific drugs to keep while handling emergency when patient is not at home or hospital?
Obviously, the last two slides which I have shown you, the nosodes in high potencies, 1M, 10M, 50M, CM, and the drugs like opium and carboveg and antimtart and all, they need to be kept. Nowadays, going to an ICCU, taking the patient from place A to ICCU, that itself is a very dangerous. You may not, like in India, it's not always feasible that the patient may survive the entire ordeal. So it's always better if you keep certain drugs at hand. Why not keep, if you're a homeopath, particularly you should keep a emergency kit. It's very handy. So the purpose of showing you the last two slides was what drugs should be kept in handy for infections or for metabolic crisis or in emergency situations, what you can use. I forgot to add aconite here. Aconite also should be kept in all potencies. Both the aconite napellus and aconite ferox, both the aconites, napellus and ferox, both are emergency medicines.
Next question is, when the pathology is severe, does high potency administration causes an aggravation? No, it doesn't. Now, when you use very high potencies, don't repeat it often. Repeat it less. If you're using low potencies, the advantage is you can repeat it often, but then you don't get that good a result as you get in high potencies in emergencies. Particularly if the symptoms are completely matching, you should not go for low potency, you should go for high potencies, but then give time for the constitution to accept that potency and act. Don't keep on repeating every 5 minutes or 10 minutes, because many times what I have seen is the homeopath is more fearful rather than the patient. So you are more expectant. The moment I give the remedy, it should act ASAP. It's not the case. So you try your very level best, but don't, as you increase the potency, your reputation should go down. That's the common rule. Next question is from Dr. Ridhima Gandhi. How Gelsemium 1M was prescribed and continued in first case, how the case further progressed, and you directly jumped to the
why was Gelsemium given was on the symptoms. I'd given you a separate slide. The reason for selecting that was only a telephonic conversation, and that too a wife, not even the patient was directly not talking to me. The patient was, they contacted me when they started from the home, and during the entire car journey, and then admitted in the ICCU in between the break thing. And yet I had to take these symptoms and prescribe. So 1M was prescribed because the symptoms were matching with gelsemium, and it responded. They could avoid a rescue PTCA. Now, avoiding rescue PTCA, saying no to a rescue PTCA is a very bold step. No, you can't do that in an ICCU because, first of all, even if the patient does not agree, the relatives will say, sir, please do something, save my patient. If you want to do angioplasty, do it. If you want to do a bypass, do it. They are not going to say no. But in this case, the patient himself has given a testimony. That's why the reason I had presented a video before that, and then the actual case. So the same case I had presented. The first case was in the slides was the case of the interview.
Next question is, how long do you wait before changing the remedy in acute conditions, that is with the pain, heart rhythm affected?
No, I mean, that is totally individualistic. It's very difficult to say how long to wait. That's totally up to your confidence. Second, the patient's response and the remedy and the potency chosen. So it cannot be generalized how long to wait. But no, it cannot be generalized because they are all emergencies we are talking about, and emergencies will can kill the patient in minutes. So seeing the patient in front of you and the response to a remedy, you may change it. It can be as early as 5 minutes or 10 minutes, or it can be as late as 3 times a day or twice a day, whatever.
Does homeopath courses need to be lifelong for patients who does have lifelong diseases?
No, not necessary. At least 3 to 4 years. And if they are symptom free in 3 to 4 years, and if your constitutional medicine is correct and they start getting laws of cure, they should display one of the laws of cure, then 3 to 4 years is sufficient. And then another 3 to 4, 2 or 3 years of follow-up without medications, only on placebo or no placebo, and then they are symptom free basically. The problem comes is, the only biggest problems in India at least comes, you cannot stop all medications. So for example, in patients, IHD patient, ischemic heart disease patient, you cannot stop aspirin. Even if they don't need, you legally cannot stop as a homeopath. If the allopaths, my case is different. So because I have both the degrees, so that don't go on my case. But homeopaths cannot stop the drug given by allopaths suddenly, even if the patients, so you have legal issues here. So that's a thing. Otherwise, 3 to 4 years is more than sufficient for a good homeopathic follow-up. You don't need lifelong. What are the remedies for hypertension and high cholesterol levels? Dr. Tejasvi, I have prepared a hypertension protocol. My school is there from 13th to 19 December, winter school. If you want to register, you can contact us on 930-7965-618. There I'm going to display all the protocols, and my textbook of homeopathic cardiology is about to be published. So there you may have. So there's not a single remedy that for all emergency hypertensive patients to decrease their blood pressure, you have only one drug. No, there are so many, like I showed you in the chest pain, so also with hypertension.
So one question is there, how and when digitalis is used in cardiac emergencies?
Well, digitalis is supposed to be the milestone for heart failure patients. That milestone and the other remedies, the other 6 remedies which are chiefly used with digitalis are, as compared to digitalis, are Adoniswar, Convalerium, Ajalis, etc., etc. Now, digitalis. Number 1, digitalis congestive cardiac failure has got bilateral congestive cardiac failure. That means right and left heart failure. If you have got exclusive left heart failure, you would hesitate to use digitalis. Right heart failure, but if it's bilateral, digitalis is number 1 remedy. Second, slow pulse, irregular pulse more than regular. If you have to compare irregular and regular, it is irregular pulse as compared to. Then the pumping capacity is obviously low, less than 30%. So it's heart failure. And certain other features, like if you have got white pasty stools, excessive nausea and vomiting, slight jaundice or discoloration, or liver enlargement, then it goes more in favor of digitalis as compared to any other failure remedy, pathological simillimums of failure drugs.
That's all about the questions. Over to you, Dr. Kavita. Thank you, Dr. Aadil.
Thank you very much. And I hope Kavita keeps on inviting me. And
Yes.
love to talk on different aspects, because cardiology is a huge subject. And my hashtag is Dil Ki Seva Aadil Se in Hindi. So Dil means heart, and Aadil, my one part of my name is heart. So anyway, so it was a lovely meeting you all people. Those who are old to me, I keep them meeting on YouTube and other platforms, social platforms. And those who are new, it was fun meeting you. See you sometime, some other time. Thank you very much for inviting me, and wish you all the best in your future endeavors.
Thank you so much, Dr. Aadil, for this wonderful session. And yes, we will bring you again soon. And since we had you in the last year and this year, it was a great honor for us too. And we have learned, everyone in this webinars, learning many new things from you, very helpful tips, especially that ESRA protocol and several remedies to handle the ICCU cases. So, and that is the need of the hour too. So that is really wonderful. And we would like to take privilege to honor your gracious presence and for your precious time in sharing your knowledge and wisdom at our study group with our caste certificate. So please kindly accept it from our team. Dr. Sweta.
Yes.
Thank you so much.
Congratulations.
And just we will take a minute to announce the upcoming event. So in December, we have homeopathy based on Hahnemann's organon and the chronic diseases by an eminent speaker from Netherlands, Ewald Stotler, on December 5th at 9 p.m. same time and 10:30 a.m. Eastern. And we have many more renowned homeopaths lined up for our CA webinars. And I would sincerely thank once again our CA Homeopathy Study Group team for the continuous support and for all the CA activities and beautiful webinars. Today we have many CA volunteers, Dr. Hiralal Agarwal, Dr. Nupur Shah, and Dr. Lakshita, and Dr. Poonam, and many more. And many are watching on Facebook Live. So, and we have different people from different parts of the world. Thank you so much for your precious time and undivided attention. And Dr. Sweta, would you like to wrap, please?
Yes, ma'am. Thank you, Dr. Aadil, for your gracious presence at CA Homeopathy Study Group platform, and much thanks to all the viewers for joining us today. And we have such more knowledgeable webinars for you. We have lined up such knowledgeable lectures, and for future updates about us and CA webinars, you can follow our social media channels like Instagram, Facebook, Twitter, LinkedIn with the name CA Homeopathy Study Group. And for any queries, you can email us at CA Homeopathy Study Group at gmail.com. And you can follow our YouTube channel with the name Kavita Kukunur for webinar recordings. And thank you all for joining us today. Shall I wrap now?
Dr. Sweta, and thank you all once again, Dr. Aadil and everyone.